targets the synovial, but it can involve the other system. The most importantly, eyes, lungs, where it causes rheumatoid lung diseases, and it can also involve the blood vessels, which leads to the vasculitis. It do involve the other parts of the body, such as heart, and all the three layers of the heart, including pericardium, myocardium, and endocardium, can be involved in patients with the rheumatoid arthritis. So this is actually a systemic type of the disease, which has systemic manifestation as well as the articular manifestation. So it usually involves the synovium, which is the primary target of rheumatoid arthritis, leads to the synovial inflammation. So this synovial inflammation has predilection and causes the proliferation of synovium, which leads to the loss of the articular cartilage, and particularly the erosions at the juxta-articular bones, which is the hallmark of this type of this rheumatoid arthritis. So rheumatoid arthritis leads to progressive joint damage if not treated at earlier stages or before the development of these joint damage or erosions. So it can be prevented or can be regressed if treated at earlier stages. So this progressive joint damage can lead to the joint deformity, which these patients may develop if not properly treated, or the patient is having severe untreated diseases. So sometimes these patients do have extra-articular manifestation along with the involvement of the joint, as discussed earlier. The most important is the ocular manifestation or eye involvement, and rheumatoid lung disease and rheumatoid vasculitis, but it can also involve other parts of the body as well. So the natural history of this rheumatoid arthritis is very important, because it is the most common type of arthritis, which affect around 0.5 to 1% of the generalized population. This is actually the data type from the European countries, but there is no data available here in Pakistan as well as in the Asian countries. So this is the common disease as other rheumatological disorder, which affects the female, with the female to male ratio of 3:1. So it typically affects the females of late childbearing, that is most late 30s, which is called as the first episode, and it can affect the female after the age of 60s. So this can be the second episode of or second mode of the disease presentation. So it has actually the bimodal presentation. One is the early 30s and second is the late in the 60s. So the causes of rheumatoid arthritis remain unknown, but it has the environmental and genetic influences which cause genetic mutation. And the most common involved genes are HLA-DR genes, which has to be go for the mutation, and that is called as second hit phenomena. So they actually have one gene error, and the other gene error develop because of the environmental factors, or sometimes the other factors including the X-rays or some other rays. And drug do play the role in the development of the rheumatoid arthritis with the second hit phenomena. So this rheumatoid arthritis actually has irreversible loss of articular cartilage and bone that usually begin after the onset of rheumatoid arthritis, even after the days or weeks after the development of these rheumatoid arthritis. So the early intervention needed to improve the long-term outcomes. So this is called that if the rheumatoid arthritis diagnosed at earlier stages and treated at the earlier stages, the patient usually have better outcome in comparison to those who diagnosed later and treated improperly. So the articular manifestation of this rheumatoid arthritis actually predict that the usual patients, they have insidious onset of pain, stiffness and swelling, and this is in the symmetrical fashion of the multiple joints, which called the polyarthritis and polyarthralgias, over the weeks to months and before presentation of the patients. So there may be a fulminant course of the disease where it present as acute rheumatoid arthritis, where the patients usually have presentation over the days or weeks, but it's less common in comparison to the insidious onset type of the arthritis. So the rheumatoid arthritis can be present in any way. It may be present in the monoarticular fashion when the patient only present with the single joint involvement, or it can be present in the form of oligoarticular or oligoarthritis, and later on these patients really develop a typical pattern of polyarthritis and with the symmetrical pattern. So the palindromic rheumatism is a term which is used for the patients of rheumatoid arthritis, where the single joint involved frequently, and the disease recurrently occur in the single joints. So sometimes it confused with the rheumatic fever, or the patient may have sometimes the arthritis mutilans of the psoriatic arthritis. But we should keep eye that the patient may be having palindromic rheumatism if a patient comes with the recurrent involvement of the single joint. So the extra-articular features can be seen at the time of presentation in these patients. The most commonly is the eye involvement leading to scleritis, episcleritis, or scleroplasia. The most common is scleritis in these patients. The systemic symptoms they do occur in these patients, including fatigue, low-grade fever that is up to 100 Fahrenheit, and weight loss if the disease remains active. So the weight loss is not significant or not seen usually in those patients who are having mild disease or controlled symptoms. So the distribution of the joints are very important because it's a disease which almost always involves the small joints of the hand, but it can start any joint of the body. So the most patient they report pain and swelling and in the stiffness. The stiffness is usually more marked in the early morning. So the involvement of the small joints that usually occur before the large joints, and the most common pattern include the involvement of the proximal interphalangeal joint, metacarpophalangeal joint, and the metatarsophalangeal joints. The metatarsophalangeal joints do involve along with or before the proximal interphalangeal joint in few patients. So the later they extend to involve the large joints of the body, including the joints of the upper limb, that is wrist, elbow, and shoulders. Also it can involve the joints of the lower limb, including hip, knee joints, and ankle joints. So morning stiffness is the hallmark and prominent feature of the rheumatoid arthritis, and it remains worst upon arising in the morning and sometime after the prolonged rest. So this may be present in or with the activity, which is also the hallmark of this rheumatoid arthritis. So the articular manifestation include the most commonly involved joints, that metacarpophalangeal joint, proximal interphalangeal, metatarsophalangeal, and the larger joints. They involved in asymmetrical fashions. So the rheumatoid arthritis can involve the spines. The most commonly cervical spine, including the C1 and C2, which is called as the axial joints, but it is less common in dorsal or lumbar and the joints of the sacroiliac area. So the hands are most involved in every patient, and these hand involvement responsible for the significant disability seen in patients with the rheumatoid arthritis. So the hand involvement may lead to the ulnar deviation of the fingers, swan neck deformities, boutonniere or buttonhole deformities. So here you can see the typical rheumatoid hand having fusiform swelling of the proximal interphalangeal joints, along with the boutonniere deformity of the different fingers, and there is wasting of the dorsal surface along with the shiny skin. You can also see the swelling over the right wrist as well. So here you can see the swan neck deformity, where you are having the fixed flexion of the extension of the proximal interphalangeal joints. This is the most common deformity seen in patients with the rheumatoid arthritis. The benignant deformity can also be seen in these patients where the patients have extension of the distal interphalangeal and fixed flexion of the proximal interphalangeal joints. So here you can see the complete subluxation of little finger of the left hand along with the subluxation of the metacarpophalangeal joint and ulnar deviation of the metacarpophalangeal joint as well. So here you can see the ulnar deviation and subluxation of different metacarpophalangeal joints, which is significantly present in these joints. So the risk can be involved in most of the patients and can lead to radial deviation of the wrist, as well as in severe cases can cause volar subluxation. Volar subluxation means subluxation of the joints towards the palmar surface of the hand. So the synovial proliferation can be seen in these patients, which leads to carpal tunnel syndrome, which is also present in patients with the rheumatoid arthritis. So here you can see the volar subluxation of the different digits. The most important is 5th and 4th digits. The feet can be involved in rheumatoid arthritis, particularly metatarsophalangeal joint that usually involved in earlier stages and in most cases. The radiographic erosions can occur as early in metatarsophalangeal joints as early in hands. Here you can see the subluxation of the metatarsal heads along with the developing ulcer over the second metatarsal head because of the significant or continuous stroking of these metatarsal head over the ground. So the valgus deformity and pes planus is another deformity seen in patients with rheumatoid arthritis. Here you can see the valgus deformity of left foot along with the overlapping of the digits and flattening of the feet, which is called as pes planus. This is actually the hammer toes and overlapping of the digits, which is also hallmark as a significant feature of the rheumatoid arthritis. The large joints, including knees, ankle, elbow, hand, hip, and shoulder, can also be involved in these patients. Usually the disease involved at later stage to these joints after the involvement of the small joints of the hands and feet. So the medial and lateral compartment of the knees, both are symmetrically affected in comparison to the primary osteoarthritis, where the joints can be involved in an asymmetrical fashion. Synovial cysts can be present over the small or large joints, but most commonly over the wrist joints. So commonly seen at knee, which is called as Becker cyst, and Becker cyst can cause problem by compressing the popliteal nerve, popliteal artery or vein, or sometimes rupturing of this popliteal into the cough, which is sometimes confused with the presentation of deep venous thrombosis. So here you can see the synovial cyst that is communicating with the articular cavity over the wrist joint. The cervical spine can also be affected or can also be involved in rheumatoid arthritis, and while it really spare the thoracic, lumbar and sacral spine. So the bony erosions and ligament damage can all lead to the subluxation, and the patient may have hanging with the Contraindication subluxation. So, rheumatoid nodule can also be seen in the tendon lines, the most commonly over the elbow and Achilles area. It can present in the lungs as well as in the eyes. So the scleratus, epischleratus, they both occurs in rheumatoid patient with the frequency or prevalence of less than 1%. So the scleratus usually cause severe ocular pain and dark red discoloration. So the scleroplasia perforans can also be seen in patients with the rheumatoid arthritis, where the sclera can become thin even in the absence of overt inflammation and leading to the scleroplasia. So the epischleratus you can see in patients with the rheumatoid arthritis. Scleroplasia, you can see the thinning of the sclera and melting, leading to the blackening of the areas. So the inflammation of the lid is called as blepharitis, can be present in patients with the rheumatoid arthritis. You can see the prominent blepharitis of the left upper lid. So for the diagnosis of rheumatoid arthritis, we usually follow the ACR and EULAR classification criteria, where you have 4 components for the diagnosis of rheumatoid arthritis, including the first component is joint distribution, the second is serology, and third one is the duration of the symptom, and fourth one is acute phase reactive, including ESR and CRP. So the joint distribution is very important in these patients, along with the duration of the symptoms. So the duration should be more than 6 weeks. So if it is less than 6 weeks, so it consists of 0 point. So the serology is very important in patients who are having rheumatoid factor or anti-CCP negative. They consist actually 0 point, and if the patients are positive with the low titer, we give them 2 points, and the patients who are having high titer, they actually have 3 points. So when we calculate all these components, the patient should have more than 6 points for the definite rheumatoid arthritis. So if the patient is having score of less than 6, we usually follow these patients for the future development of rheumatoid arthritis. We do not label them as the patient of rheumatoid arthritis, but we do follow them and to actually include in the diagnostic criteria of rheumatoid arthritis. So for the diagnosis of rheumatoid arthritis, according to the ACR and EULAR classification criteria, we need to have 6 definite points to label them that the patient is having rheumatoid arthritis. So the investigation for the rheumatoid arthritis, we will get baseline investigation of blood CP, where we can see the anemia, which is proportional to the disease activity, and it's usually anemia of the chronic disease, where the MC and MCH and MCC remain normal in these patients. So the hemoglobin, if it is because of the disease activity, the hemoglobin usually becomes to the normal when the disease is controlled with the treatment. So the leukocyte site may be normal or high or sometimes low in these patients. The low leukocyte count usually predict that the patient is having sometimes Faraday syndrome or other connective tissue disorders such as systemic lupus erythematosus overlaps. So one should keep the eye if the patient is having low TLC count. That is very important in patients with rheumatoid arthritis. The thrombocytosis is again the reaction of the body to the inflammatory response, and it also predicts that the disease is active in these patients. ESR and CRP, it also included in the diagnostic criteria of rheumatoid arthritis, and these both inflammatory markers actually have parallel with the disease activity, and the persistent elevation of these ESR and CRP portend that the patient having poor prognosis. So the autoantibodies in patients with rheumatoid arthritis includes rheumatoid factor, and anti-CCP. So the rheumatoid factor is actually an antibody that binds to the Fc portion of the immunoglobulin G, and it preceded the onset of rheumatoid arthritis for many years, even 10 years before the development of symptom of the patient with rheumatoid. But it can be false positive in patients with the connective tissue disorder or sometimes in few infections such as tuberculosis. So one should keep the eye with ACR and ELR criteria that the patient typically should have the joint involvement and along with the duration of more than 6 weeks before labeling, as the rheumatoid factor is not specific for the patients. They actually have negative rheumatoid factor at the initial stage of the disease, but later on as the disease progress or with the passage of time, they become seropositive when this rheumatoid factor become positive in the serum or blood. So they are labeled as seronegative initially, and later on they label as seropositive rheumatoid arthritis. So the anti-CCP is another antibody and very specific for the rheumatoid arthritis. This anti-CCP is produced by the rheumatoid synovial, especially tissue with the lymphoid aggregates. So anti-CCP are present in the serum of around 80 to 90% of rheumatoid arthritis patients, and more specific than the rheumatoid factor, with the specificity approaching more than 90% in patients with the rheumatoid arthritis. It also appears long before the development of symptoms in patients with the rheumatoid arthritis, even 10 years before the development of symptoms in patients with rheumatoid arthritis. It is also a marker of the subclinical inflammation in these patients. So the rheumatoid arthritis is also associated with the other antibodies such as ANA. So these patients usually have positive ANA in around 30%. So it also predicts the poor prognosis in these patients. So the Pianka can be seen in these patients, which is actually because of the rheumatoid arthritis, but not because of the ANCA-associated vasculitis. So the radiology often remain normal at the initial stage of the rheumatoid arthritis. It usually require more than years to have radiological evidence or radiological findings of rheumatoid arthritis on the X-rays. So the erosion of MTPs may be detected prior to the changes in the hands. So the initial finding in these patients of rheumatoid arthritis remains soft tissue swelling, marginal erosions, joint space narrowing, and deformities or distinction on the X-rays. So here you can see the X-ray of wrist, where you can see the significant erosions at the area of radial as well as ulnar margins and the carpal bones as well. So you can see the normal X-ray of the knee. This is the primary osteoarthritis, where you can see the narrowing of the only medial compartment of the knee joint, while the lateral compartment is normal. You can see the symmetrical narrowing of the knee joint on the medial as well as on the lateral area. So this is actually the secondary osteoarthritis, like the most common associated with the rheumatoid arthritis. So the treatment of rheumatoid arthritis this remarkable effect has been come about because of the expansion of the disease-modifying drugs, especially the availability of the Methotrexate. So these drugs should be used in combination where it needed. Although we can use a monotherapy in patients who are having very low disease activity. So if the patient is having moderate or severe or very severe disease, ideally the combination of disease-modifying drugs should be started in these patients. So rheumatoid is a chronic disease, and so that's why it requires a lifelong treatment of these patients. So the treatment should always be started with the counseling. The rheumatoid arthritis is a lifelong disease, and the patient may need a lifelong treatment to prevent or to decrease the progression of the disease. So the available therapies are very effective if it started at earlier stage in patients with the rheumatoid arthritis. And the therapeutic approaches should be more aggressive for patients with early rheumatoid arthritis and those patients who are having feature of poor prognosis, such as the patients who are having functional limitations, the patients who are rheumatoid factor or anti-CCP positive, the patients who are having erosion on the X-rays, and the patients who are having extra-articular manifestations. Also the ANA is associated with the poor prognosis as well. The pharmacotherapy included, there are three broad categories of the medication used for the rheumatoid arthritis. One is the synthetic disease-modifying anti-rheumatoid drugs. The other, second one is biologics, and the third one is glucocorticoids. So Better and optimal control of the disease activity often requires more combination of different synthetic disease modifying drugs or synthetic and biologic disease modifying anti-rheumatoid drugs combinations. So the recommended in this 21st era is combination of the synthetic disease modifying and biologics. So the disease modifying drugs included the conventional and biologics. The conventional disease modifying drugs most commonly used are methotrexate, hydroxychloroquine, sulfasalazine, leflunomide. So the previously gold values purchased very toxic drugs, so that right now it's obsoleted from the treatment of rheumatoid arthritis. We can use other drugs as well, including azathioprine, minocycline, cyclosporine, or penicillin, and sometimes glucocorticoids in those patients who are contraindicated, who have contraindication to other disease modifying, or where you have not better control of the disease. The biologics included TNF inhibitor, included etanercept, infliximab, and IL-1 inhibitor, which include anakinra. Deformity is another TNF inhibitor. Abatacept and rituximab actually is a CD20 antibody. Certolizumab is also a TNF inhibitor. And the newly coming drugs, which include IL-6 inhibitor, which is tocilizumab. So the group of medication that have the ability to modify or the change of the course of the rheumatoid arthritis, it actually requires 2 to 6 months to have their maximum effect. So the low dose glucocorticoids up to 15 milligram may be needed or may be used along with these synthetic DMARDs to cover these 2 to 6 months to having maximum effect of the disease, maximum effect of these disease modifying drugs. So this steroids actually bridges with the synthetic DMARDs or conventional DMARDs. So the choice of the disease modifying actually depends upon the activity of the disease. Either it's low activity, moderate, or severe, and comorbid condition, such as the patients who are having lung diseases or the patients who are having liver problem. The methotrexate should always be avoided in these patients. So also the toxicity, because these are conventional as well as synthetic DMARDs are very toxic drugs. So one should take with the cautious in these patients. So the monitoring issue is another important issue in these patients, because these drugs do needs monitoring in these patients, especially the methotrexates. If the patients who have poor compliance with the follow-up, so the less toxic drug should be used in these patients. So methotrexate is always the preferred synthetic disease modifying drug in patients with rheumatoid arthritis. It can slow the progression of the radiographic progression of the rheumatoid arthritis. So it also effective as a monotherapy in patients who are having low to moderate disease. So it usually administered as a single weekly dose that is given per kg of body weight, per kg of the surface area in pediatric patients, but can be used up to 25 milligram in adult patients, and that is started with 7.5 milligram as a single weekly dose. So the monitoring of methotrexate should include complete blood count, liver function test, and serum creatinine, and sometimes they need X-ray or CT scan of the chest, where you have suspicious that the patient having methotrexate induced pulmonary toxicity, that is hypersensitivity pneumonitis. So the contraindication to methotrexate included the patients who are having liver disease, patients who are having alcohol, and patients with chronic kidney disease having creatinine clearance of less than 30 ml per minute. The side effects include oral ulcers, nausea, vomit, statin. It is a toxic drug. It can cause bone marrow suppression, and sometimes it causes hypersensitivity pneumonitis as well. So the hydroxychloroquine is another DMARD usually used in combination with the other drugs. More importantly, with the methotrexate, it's the least effective and least toxic disease-modifying drug, and given at a dose of 200 to 400 milligram daily or 6 milligram per kg of the body weight. So its toxicity included retinal toxicity, where it causes retinitis. Leflunomide is another DMARS, and it is also used as a single or in combination with the other disease-modifying drugs. It's usually given as a single daily dose of 10 to 20 milligram per day. The most common toxicity is diarrhea and hepatotoxicity. Monitoring is recommended in these patients in the same way as methotrexate. So the biological disease-modifying reduces the sign and symptom of synovitis in patients who have active disease despite using methotrexate. So that it can diminish the radiographic progression of the rheumatoid arthritis. The onset of action is rapid, that is days to in comparison with these medication is actually the cost. It's very expensive drugs, so it should be used judiciously in these patients because of the cost. So it can increase the risk of infection. So the screening before starting of these medications are needed for the tuberculosis, hepatitis B and hepatitis C infections. So the etanercept is a TNF inhibitor which is used in patients with rheumatoid arthritis. Rituximab has been used in these patients, which is a CD20 B cell antibody. Abatacept is a T cell co-stimulator immediate, and it has excellent result in patients with the rheumatoid arthritis. Tocilizumab is an IL-6 receptor blocker, which is newly launched biologic DMARS, and it's available in the subcutaneous form as prefilled syringe in patients used in patients with rheumatoid arthritis. Glucocorticoids usually used as bridge therapy in combination with the disease-modifying drug. It is rarely used as monotherapy, and sometimes it's used as in patients who are having single joint involvement as intra-articular, in the form of intra-articular injection. So the low dose of glucocorticoids provides a rapid and symptomatic improvement in these patients. It can slow the radiographic progression of the rheumatoid arthritis, but is not recommended as a monotherapy. It can help to control the inflammation while initiating therapy with the disease-modifying drugs, or when response of disease-modifying drug is suboptimal. So in that case, the glucocorticoid can be used for a short period of time. So thank you so much. If you have any question, please let me know them. If you have any question, please